Tak dobrý den a z úcty k našemu vzácnému hostu já rovnou přepnu do angličtiny. I will switch to English right now, today. And it's a great honor to welcome a giant of nuclear medicine here. If you follow our social networks, then you had to catch the fact that Professor Alavi is already here. I guess you have read his CV, short CV, which we have presented. And I wanted to ask, who of you have Netflix? Who of you? It's not a shame. Raise your hand. Okay. And there is one series, a documentary series about a guy who has fulfilled his dream and influenced many people. His name is Arnold Schwarzenegger. And I have to say, I see many similarities between Abass Alavi and Arnold Schwarzenegger, although they are not on the first sight. Yeah? Arnold has slightly more muscles. Anyway, Abass has much more brain. But what they share is the mentality to push through, to succeed. The story of Abass is something very inspiring. And coming from very modest conditions in Azerbaijan, in Iran, living in very modest conditions with his mother, and after his father died, when you were 4, you said, very early, in very I would say, demanding conditions. Yeah? Grew up, he always wanted to be good or the best. He became the physician because his mother told him to. Otherwise, he would like to do the science. He was very good in math. And after getting to America, he started to work to fulfill his dream. He has found nuclear medicine as a very potential specialty with a high potential, and made a lot of contributions during his career. So one of his biggest contributions is that his right hand, was it the right hand or left hand, was the one holding the syringe with the first FDG application or administration in the world, which started and changed the history and prepared the field for all of us. So Abass, thank you very much for coming to Czech Republic. We are extremely honored. I have to warn you, Abass is very open and he will speak to any of you anytime. But after you speak 10 minutes with him, you will start to feel spoiled, comfort, and lazy. Because Abass, 86 years, age is just a number. That's the first thing he said after getting out of the plane. And then he said he's working 6 days a week, 10 hours a day. So I think this is admirable. We are really glad to have you here. Thank you for coming for such a long journey. And we as a society would like to honor you with our honorary membership, which allows you to visit our Congress for free. So thank you very much. Thank you very much, Abass. Thank you. And enough of me. The star of the evening, the star of the afternoon is Abass. So let me just, my last words, thank you for attending this lecture. Thanks to the firm MGP for supporting this lecture. Thank you. My thanks are also to Michal, who will do the camera and who will do the movie later, and to Czech Medical Association for providing this place. Now the floor is yours.
Well, thank you very much, David. It has been a... Yeah.
Forward, laser, but you need to hold it a little.
Okay.
Yeah, then you will see this.
Okay.
Yeah.
All right, and then that's forward.
Okay.
Well, Ella, it's been a great pleasure to visit your country and definitely spending time with David in the past 2 days. They have got a great country, a lot of great people, and my job as someone who really enjoys working with different people from around the world, especially young people, that's my really major source of pleasure. I have like 20, 25 students who work with me, and meeting a lot of young people is a major source of pleasure for me, because I really want to influence young people to really choose, our specialty, which is a very promising specialty. And, I've had the pleasure talking to a lot of young people, and I really appreciate the opportunity that I've had during the past 2 days. So what I'm going to do is really talk about some concepts that really need to be emphasized in our field. I've been telling everybody that, in my view, molecular imaging PET is the most important discipline in medicine. We are going to really make a major impact on practice of medicine, understanding disease process, developing new drugs. So this is a very, very major development in this field, in medicine. And I think we have been very fortunate to really be in it right from the beginning, especially introduction of FDG to medicine has made PET to survive. Without FDG, that wouldn't have happened. So really, that's also a source of pleasure for me and my colleagues at Penn, really, who were instrumental in making this a reality. So I want to just tell you a little bit about what's happening with molecular imaging, and especially as it relates to looking at some domains that are very important, because that's really what David wanted me to just talk about and see how we could introduce new domains that have not been as well as explored. So if you got to the literature, you will see that fluorine-18 was used in 1962. That was actually before even technetium generator was introduced. This colleague, Bulal, actually is not even a physician. This was a physicist, and he used, of course, sodium fluoride for, of course, they got fluorine-18, without them saying sodium fluoride, for bone scanning. And of course, that's really how nuclear medicine started. Of course, we used it rectilinear scanners. We were just looking at one point at a time with these focus collimators. That's what they call it, rectilinear, because it went like this. So this guy, Montebello, did the first fluorine-18 images, and that really was the beginning of our field as we know today. And then, of course, soon thereafter, there was introduction of strontium, and that it actually was done by a colleague in Philadelphia. David Sharks was in Temple. And so this was the beginning of looking at bone scanning as evidence for cancer. And of course, the group in Syracuse, by this colleague, is an Indian colleague who worked with John McAfee, introduced technetium phosphates. So this really opened the door for starting nuclear medicine in a big way. So having technetium phosphates, which still is being used around the world, were just very important developments in our field that make our field to survive. But as we really have gone through, of course, bone scanning for cancer and other benign diseases as well, have been very important. But my concern has been looking for cancer with bone scanning alone, because I just want everybody to be aware that cancer doesn't go to bone. Cancer goes to red marrow. So red marrow is where cancer goes, and if you want to see cancer, you got to look at directly where cancer cells are. So looking at bone scan for evidence for cancer is going to delay your diagnosis, because it takes a while. When cancer in the red marrow starts to irritate the bone, and therefore see evidence for cancer. So it is insensitive for early detection of cancer, and therefore delay treatment of patients with metastasis. So bone scans, even with fluorine-18 with modern PET machines, is not going to be as sensitive as we would like, because it is very delayed. Similarly, when you treat the patient with cancer systemically, of course, chemotherapy or whatever else you're using is going to kill the cells wherever they are, in the primary sites, in the lung, in the breast, and it really takes a while before the evidence for cancer in the red marrow disappears. So you're going to have a lot of really time lag after the cancer has disappeared from the red marrow to see changes on bone scans. So doing bone scans, either for early diagnosis or seeing response to treatment, are not going to work well. I mean, this is unfortunately still the case. A lot of people have bone scans either with fluorinating fluoride, with PET, modern PET machines, as well as, of course, phosphates that are used on SPECT machines, are not going to survive the test of time because it really is insensitive for early diagnosis, is insensitive for seeing what drugs you're giving to the patient are really helping these patients. So, you know, during the past 20 years, we have been writing editorials about bone marrow, not bone as the primary site for skeletal disease. So it's actually one of my Indian students who really a very talented guy, Sandeep Basu. We just wrote this letter to the editorial Journal of Clinical Investigation, Journal of Clinical Oncology, which is a very famous journal. And there was a paper that we're proposing to use the bone scans, and we just wrote this editorial saying that fluorinating deoxyglucose, which goes directly to cancer in the red marrow, should be the way to diagnose cancer. Because ever since we have written several editorials, you will see this, the concept of imaging bone marrow metastasis is really very important, especially with the introduction of FDG PET, but as I will discuss, other traces, like looking at PSMA in patients with prostate cancer. So we want to diagnose cancer in the red marrow soon after it occurs, rather than wait to see a bone scan become positive, because it's going to take a few months or maybe longer for bone scan to become positive. So we have these editorials, and I have a few of them here. This is actually a colleague from the Odense, Denmark, you know, with whom I've worked, and this was, of course, cancer metastasis to bone marrow, not the bone, time for a paradigm shift. And this is another one of one of my students, medical students, who really wrote this also. Metastatic seeding attacks bone marrow and not bone, rectifying ongoing misconception. So don't do bone scans for cancer. In the era of direct visualization of cancer cells, we got to use specific traces, especially, as I said, just with the introduction of like PSMA, which is a major cause of metastasis to bone marrow from prostate, is really making this paradigm shift in the way that we're going to assess patients with cancer. So, of course, we introduced FDG in 1976, and this was, of course, the total body PET machine, that total body image that I did with rectilinear scanner, the same thing that Monty Below did in 62. I used that type of approach to build this machine. We didn't have a PET machine to do whole body as we have today. Now we can do in 2 minutes the entire body imaging. We didn't have any possibility of doing that at that time, but I just want to show the distribution of FDG. But this showed that if you have got a specific tracer, like FDG, that detects cancer wherever they are, it's going to change the way that we look at patients with cancer. Of course, we have used FDG to look at 8 major common diseases of mankind. Our motivation for FDG was to look at central nervous system disorders, Alzheimer's disease, seizures, and so on. But cancer has become a big part of our activities around the world. Of course, this has application of FDG in cancer has made PET to survive. Without cancer application, that wouldn't have happened. So that was, of course, a major development. Of course, infection, inflammation. These are 2 most common diseases of mankind. We have been looking, I'll show you some examples, of arteriosclerosis, looking at plaques with macrophages, detection of clots and myocardial viability, and many muscle dysfunctions. So really, this one agent has so many major applications, and of course, among them is cancer. So this is, of course, an image of patient with multiple lymphoma metastasis before and after treatment on and coronal and the transaxial images, and of course, see it in black and white. So, what happens with red marrow, which is very important for you to realize that when you are a baby at birth, in order to make your body survive and grow, you have to have a lot of oxygen in the body. So you make red marrow in your forearm, in your fingers, as well as in your toes. So this is at birth. As we get a little older, bone marrow starts to shrink. So by the time that you are 19, 20 years old, the red marrow is completely disappeared almost from lower and upper extremities. So that's why you don't see someone with metastasis to the fingers or toes, because there's no red marrow. And that is, of course, and that's, you see it on the images here, that if you are young, you have a lot of marrow in the proximal femurs, but when you are 60, 70 years old, you have very little red marrow here. So that's why actually we also don't do whole body imaging for cancer. We stop in proximal femurs, and that's just a right way to go, although I will discuss about the possibility of detecting clots. Patients with cancer develop clots in their femoral vein, in their popliteal vein. So we think that it should be done not for detecting metastasis, but for detecting clots. So this is really why the majority of the cancer that is detected in the skeleton is going to be in the spine, in the pelvis, so we will see, of course, because there's a lot of red marrow in the pelvis as well as the ribs. So that's where the cancer cells are going to go because of red marrow being in those locations. So this, of course, a patient with multiple myeloma, seeing all the lesions that are all over the place, ribs, spine, pelvis, and look at the bone scan with fluoride. We've seen maybe 20% of the lesions that we've seen on FDG scan of the metastasis versus bone scan that is shown in direct evidence. So really, you are going to miss a lot by doing bone scans, expecting that bone scan is going to be positive in many cancers, and definitely with multiple myeloma, as is the case. And we have really looked at this extensively, and it just shows the importance of specific tracers that go to cancer and allows us to see the extent of the disease. This is really what PET is all about, to stage the patient more correctly, as well as, of course, see response to treatment. So this patient, after treatment, as I'll show you, will show significant loss of activity on FDG scan, while bone scans will be positive for a long time. So, of course, we have been very interested in, of course, this is a patient looking at sodium fluoride images of a patient with prostate cancer. And we have been, this is something that I'd like to emphasize also, look at the entire body. I don't like to see reports that looks at 3 lesions, SUV have 10 here, SUV have 5 there, SUV have 2 there. They make no sense. But when you use these programs, this is actually a program from ABX in Germany based on the work that we did at Penn, segmenting all the lesions and coming up with one value. For example, here is just, we have measured the entire, you see that global activity is 2,773. So these are really robust numbers. It's not really statistically invalid numbers. So we like to do just global activity as I'm showing you in this image, and that's going to be a very useful way to look at metastasis. With, of course, I'm talking about specific traces like FDG or PSMA and other. Actually, we are correlating a patient with prostate cancer with global metabolic volume product. This is really what you're going to see in the literature. And again, we introduced this concept, and there's more and more people are catching on. about using this global assessment with especially these programs like ROVR that segments these lesions, corrects for partial volume effect. And of course, here we are comparing these large numbers with alkaline phosphatase. There's an excellent correlation with p-value of 0.004. So this is, of course, a patient with multiple myeloma. There's another program that is made by a company in Switzerland called Osiris. We use this program also quite often. This is actually, I don't know if anybody uses in Austria, but it's a very nice program because this is it detects the skeleton based on bone structures. And of course, in diseases like multiple myeloma, we really think that this is the way to go. You don't have to use ROVR because this thing is actually available. Osiris is available in America, is selling for $600. So we use this quite often, and I'm hoping that you will be able to get this. So it's not very expensive. And this just segments the entire skeleton, entire spine, pelvis, proximal femur. So you will be able to, again, just see all these lesions that you see on black and white images and on these superimposed images, and be able to come up, for example, here, the patient had average value of the total lesion at 2, and after treatment it becomes 1.1. This is real. This is not something that, because of your analysis, you could make a lot of mistakes. So this is, of course, a patient, again, with skeletal metastasis due to multiple myeloma, and of course, this lesion is only detected on FDG as well as in other areas. So this is positive in the sternum and is negative on CT scan. Even retrospect, we couldn't find the lesion. So, of course, so this is, of course, a patient with multiple lesions in multiple myeloma, and look at the extent of the disease on FDG scan versus what you see on the bone scan. So again, showing that sodium fluoride bone scan is nowhere close to what you can detect directly in the red marrow of this patient with multiple myeloma. One thing that we have really done, and I like to see them more often, if you really have FDG as the main agent, is looking at early and delayed images. This is called dual time point imaging. We introduced this concept because cancer cells grow up significantly over time. So here, we're looking at this UV mean of, at 60 minutes, 100 minutes, in patients who have responded to treatment are those that it doesn't go up as much. So here's, the lesions that are lesions that, lesions that they are more responsive to treatment, have less increase in uptake over time compared to lesions that have significant rise. So really we are able to show that, but by early and delayed imaging, we can detect what cancer is bad and what is not. Bad cancers are going to go up significantly compared to more benign cancers. This is, of course, a patient with with multiple myeloma, and again, here we are looking at. I'm sorry. This patient has got CLL, chronic lymphocytic leukemia, and we are seeing, of course, evidence for global activity that we can use with this Osiris in the software that we have, and this is really very, very important for us to assess the response to treatment and what's happening. Now, we have shown that undifferentiated cancers have significantly more uptake, and therefore, cases like breast cancer, like prostate cancer, FDG uptake is not going to be as high because hormonally sensitive cancers like breast cancer and also prostate cancer that are differentiated cancers, they are not having as much increased activity as undifferentiated cancers like lung cancer or lymphomas and cancers of that sort. Now, we are also very interested, and I want to really emphasize this because sodium fluoride is available and just comes up at the cyclotron without even doing chemistry. And we have been very interested in seeing how far we can go with sodium fluoride PET imaging. So I've become very interested in atherosclerosis during the past 20 years. And of course, atherosclerosis is supposed to be an inflammatory process. So FDG being picked up in the macrophages and white cells of any kind makes it very attractive to look at atherosclerotic plaques that have a lot of macrophages in this. So in 2001, actually, I published the first paper on use of FDG for detecting atherosclerotic plaques. And so I'll show you, this is just an example of macrophages and foam cells that are in the plaques, but also, of course, here we have very, not very big, but there's also molecular calcification. So plaques have a lot of macrophages, which makes FDG very attractive to look at these plaques, but also has molecular calcification. Calcification that you see in CT scan usually comes very late after atherosclerosis starts, and therefore it's really just not as sensitive for early detection of calcification with CT scan. So we think that it's going to be very important for us to use sodium fluoride for molecular calcification. The reason that FDG may not survive, as I will show you, for looking at atherosclerotic plaque is that it's not really, especially in the coronary arteries, you're not going to be able to use FDG. But there are, of course, a lot of other tracers that have been used, carbon level, fatty acids, ammonia, and perfusion agents. But more and more, we are convinced that looking at sodium fluoride, as well as nanoparticles. We talked about it yesterday with David's colleagues in his department. Nanoparticles can be used to look at the inflammatory cells, especially in the coronary arteries. And of course, a lot of acid, acetate and all that. These have been used over the years, but at this point, we believe that sodium fluoride has got the best option, especially if you are interested in looking at coronary arteries as well as carotid arteries. So our hypothesis is that you start with inflammatory reaction. This is really at least the understanding that plaques are inflammatory in nature. If it goes on for a while, then there's molecular calcification, and then eventually, this is of course molecular calcification, eventually becomes stable calcification. So FDG will be useful to detect inflammation in the plaques, like in the aorta, carotid arteries, peripheral arteries, but not in the coronary arteries. And of course, sodium fluoride, which I will show you more evidence for it, is going to be useful for all the plaques anywhere in the body. And of course, when you see CT evidence for calcification or intravascular, ultrasound is at a very late stage. You're not going to see people with structural calcification until you are in their 40s. So by the time you see CT calcification, you have got very advanced disease, and we want to diagnose the disease as early as possible, to start the patients on anti-atherosclerotic plaque, like statins. So this is our concept that led us into our research over the past 25 years. So we also are pushing this concept that in the literature and publishing papers that disease starts at the molecular level. This is really why PET is going to be centerpiece of diagnosis of any disease, because when disease is in the molecular level, which PET is the only modality showing it in an imaging way, is going to be the way to go. So you start a disease like atherosclerosis in my country, in America, starts in teenagers. And this was actually shown during the Korean War, when the soldiers who were in the 18, 19 years old, this is actually 60 years ago. We didn't have as much obesity and atherosclerosis those days as we have today. Many of those soldiers had evidence for atherosclerosis in the very early years of their life. So you start atherosclerosis in early years, and if it goes on, then it changes function. Function is like perfusion imaging. Function is like motility. And if it goes on longer, then you start seeing CT evidence for calcification. So really waiting until you see calcification in your coronary arteries, in your aorta, in your carotid arteries is waiting too long. So by the time you have got CT calcification, there are rocks sitting in your vessels, and you cannot get it out. So number one killer of mankind is diagnosed nowadays with CT scan, and is not going to survive. I think we're going to really have to move to molecular imaging with PET, and sodium fluoride is going to be the way to go. So of course this is just showing you, if you have got more calcification, the mortality, like this where it's got a lot of CT calcification, you die, within 10 years of diagnosis, and of course you have got less calcification, you can survive. But again, CT evidence for atherosclerosis is not going to survive. These are just showing you what you see on the aorta. These are just rocks. Fortunately, aorta doesn't cause significant problem, but when you have carotid artery and coronary artery disease, you really are going to have significant problems with your blood flow to your brain and blood flow to your heart. This is, of course, one of our studies that we looked at early and delayed images of FTG. This is 1 hour image. There's a lot of activity in the blood pool. It's very hard to see the plaques, but as you go to 2nd hour, we see some more, but when we go to 3rd hour, you see evidence for calcification, and especially the arch area is very common for atherosclerosis. So this is just showing you that FTG, of course, only being used for aorta or possibly with carotid artery has to be done later. Of course, when we go this far, the half-life of fluorine-18 being 2 hours, you have to do a lot of imaging time. So with the modern, of course, total body PETs, as I will discuss at the end, we can probably afford to go to a 3rd hour because it's 40 times more sensitive than conventional PET machine. And if you're interested in seeing plaques in aorta, possibly carotid arteries, FTG will be a viable option. But this is just PET-CT showing superimposed uptake of FTG in the plaques as well as the CT evidence for calcification. We have, of course, done a major study called Common study. I work with colleagues in Denmark and Odense, Denmark, and looking at healthy subjects as well as patients with high risk. And we are looking at uptake of FTG in the inflammation, and we can just showing that, of course, in patients who are healthy, there's no significant rise of FTG uptake over years, so we're going from 20s to 60s. And when you have got high risk for atherosclerosis, we have seen evidence for inflammation in the aorta. Of course, we looked at the arch of the aorta and see the significant change over time as you get older and have got high risk for atherosclerosis. You can see that very clearly. But this is sodium fluoride, and even in young people without any risk factor, we have significant rise of sodium fluoride uptake in the arch, while in such patients with no disease and healthy subjects, FTG doesn't show significant change. So we believe that this molecular calcification is really a fantastic tool, and I think it's going to be very important tracer for looking at evidence for atherosclerosis. These are, of course, patients, sodium fluoride with high-risk patients looking at arch. Again, very significant rise with sodium fluoride. while FDG is not as sensitive as sodium fluoride is. So this is, going to be a very important approach in the future. So we have been looking at, of course, coronary arteries, and I've been talking about global assessment. Yesterday I discussed it, and I mentioned it earlier during my talk that we believe that looking at the entire heart, this is of course healthy subject, young subject, without any evidence for molecular calcification, and this is an older subject. There is significant uptake of sodium fluoride, and we believe that global measurement of the entire heart is going to be the way to go for detecting coronary artery disease. And I've been honest with you, I was just talking to their colleagues in Edinburgh that they are publishing papers in major journals, and unfortunately I'm trying to just stop them completely because they're looking at coronary artery disease as focal abnormality on sodium fluoride. That's impossible because cardiac, heart moves 70 times a minute, diaphragm goes up and down 20 times a minute, 3 centimeters, 40 centimeters. So it's impossible to look at small calcification in the coronary arteries by sodium fluoride. I mean, these people unfortunately have misled the world, but I think they are changing and it's going to stop. So the only way we can diagnose atherosclerosis in the coronary arteries is going to be exactly what I have shown here. Look at the whole heart, and I'll show you the data we have. So we have actually validated the sodium fluoride uptake in an animal model. These are pig models that have a significant atherosclerosis, and of course you see it on even focal abnormalities in this animal that we did, of course CT and superimposed, and we have actually did post-mortem studies. These animal models have been very well validated as having a lot of atherosclerosis, and you can see here, there's a very significantly high values in animals that are models for atherosclerosis and calcification compared to lean animals. These are pigs that have significantly lower activity. So we were able to validate sodium fluoride uptake in the heart as evidence for coronary artery disease, as you see there. Of course, this is just another example of, again, healthy and unhealthy. Of course, as we have looked at in a coronary artery disease with different risk factors, looking at global activity, coronary artery uptake of sodium fluoride versus risk factors. As the risk factors increase, you see significant rise in uptake of sodium fluoride with a p-value of less than 0.001. So this just shows that we really are looking at evidence for atherosclerosis by looking at the entire heart with sodium fluoride. Now, we have been very interested, and I'm talking to David about this, patients who are radiated, right, especially with photon therapy, X-ray therapy, in two areas. One is head and neck, and the other one is the cardiac area. Patients with head and neck cancers who are radiated for cancer in the head and neck region develop significant atherosclerosis in their carotid arteries. These patients develop dementia, strokes after radiation therapy. And we are able to see changes in the carotid arteries. And definitely we see inflammation on FDG scan, but also we believe that sodium fluoride is going to be a big one. Also, patients with left breast cancer, left lower lung cancers who are radiated with photon therapy, not photon therapy, have significant incidence of coronary artery disease. These are very important treatments, yet they have serious complications. So we are very interested in looking at complications of photon therapy versus proton therapy as the cause of cardiovascular complications. So these patients, like head and neck cancers, are very responsive to treatment, so are the breast cancers, yet these patients come with heart attacks or strokes due to treatments with photon therapy. Proton therapy may not be as bad as photon therapy in seeing these complications. Now, we also, are of interest to look at osteoporosis, a very serious problem, especially in women post-menopausal state. And we just don't think that CT scan should be used for this purpose. It's very delayed. You have seen it after years of osteoporosis. So sodium fluoride is going to be a very important modality for looking for osteoporosis. Sodium fluoride has shown bone formation, and therefore we're going to be able to see it. So we have looked at patients with osteoporosis, and of course this is the model that we have used, and you see very clear-cut evidence for osteoporosis, looking at SUV mean or SUV max. One thing that also I want to emphasize that we really rely more on SUV mean than SUV max. SUV max is really just very artificial, just only one pixel that is high, doesn't reflect the rest of the body. So SUV mean is, even as you see here, showing you evidence for, this thing is not, so he's showing you very clear-cut evidence that we can detect osteoporosis, but SUV mean with these data that we have generated in our lab. We cannot, of course, show evidence for osteoporosis with FTG, as you see here. That just doesn't show the sodium fluoride is significantly better than FTG in detecting osteoporosis. Now, we have, of course, moved. FTG was great, made PET to survive, 8 applications, but there's life beyond FTG. One of the exciting things about FTG in a PET is really looking at almost every disease in the brain, in oncology, in rheumatology, cardiology. So really there's life beyond FTG, and of course we really are very interested in going to theranostics. So theranostics is really a big thing, and I'm glad that a lot of people in your country, Czech Republic, are getting interested in this thing because we use diagnostic tool for the right patients and the right time and right dosage. This is really a very important part. And radiomolecular theranostic is show you already labeled compounds that for tracking treatment of the patient and response to treatment. So we treat what we see what we treat, and this becomes personal health, which is really what we're talking about in medicine. And of course, the oldest theranostic was in thyroid, both for Graves' disease as well as cancer. We have used I-123 or I-124 or I-131 for diagnosis, but also treatment with I-131. Of course, therapy is mainly by using beta emitters, but I'll talk about alpha emitters as well. So really, this is not a completely theranostic, it's not completely new. This actually goes back to really in the 60s and 70s. So we really have just a diagnostic agent like gallium-68, fluorine-18 labeled compound, and then use a chelator and just make it bind to these ligands of various kinds. So we introduce the key to the right block and open it up, either looking at some of the statin receptors or PSMA agents. So if you look at the literature, again, we have sodium fluoride, for diagnosing cancer, and diagnose with I-123 or I-131, and use I-131 for treatment, and then that for thyroid cancer or hypothyroidism. Of course, MIBG for diagnostically with either I-123 or I-131, and then therapy, neuroblastoma, and then we can use, of course, in just technetium label sodium fluoride for diagnosis. And this is actually alpha emitter, which is something that I will discuss a little bit later, and treat the bone lesion, which we don't think that is really as important as looking at cancer directly. But as we have moved to really going to directly to soft tissue tumors and gallium-68 dotatate for neuroendocrine tumors, and of course, so we can of course diagnose it and then use lutetium, which is a beta emitter. Beta emitter is just that single electrons that go very short distance and then kill the cells. And so we can treat neuroendocrine tumors And the same is really applicable to prostate cancer, looking at PSMA, either with gallium-68 or fluorine-18 PSMA, and then treat the patients with prostate cancer. And of course, we can look at the microspheres to treat the hepatic lesions. Diagnostically, we can look at technetium or even PET labeled compound, and then treat patients with hepatocellular carcinoma, cholangiocarcinoma. And of course, anti-CD20 and CD22 were diagnostically seen by iron-worm and then treatment with tritium. So really, you can see that theranostics, as we have witnessed over the past 20 years, are becoming a very important domain of research and applications in our specialty. So we've got gallium-68 linker, and then target some of the statin receptors, and just see these patients with metastasis from neuroendocrine tumor to the liver that so clearly is seen on gallium-68 dotatate. But this is, of course, showing two different type of beta emitters, yttrium and lutetium. These are really right now the hottest thing right now we have in our specialty, namely using different type of linkers and different type of isotopes. And we will see eventually which of them are going to be selected. So beta emitters are very important, but alpha emitters are gaining a lot of recognition as being more effective, because alpha emitters are much more dangerous to cell killing the DNA synthesis, and therefore this is really going to be a big domain of applications in PET. So this is the data that was published in New England Journal of Medicine. Actually, this Ghassan and Haddad is one of my past students at Penn. So this was, of course, very clearly shown that lutetium labeled dotatate for neuroendocrine tumors is effective. As I show you the images, this is before treatment, all the lesions in the liver, and after treatment, all the lesions have gone. These are very impressive evidence that theranostics is really successful. We can diagnose it, and also we can treat it. And these are just examples of gallium-68, and the label PSMA tracer, and of course the beta particles, and then binds to the receptor site in the prostate cancer cells, and therefore radiate the cell. So precision nuclear medicine with PET-CT, and these are just the patient with Gleason 9. This is the staging of prostate cancer, as typically the clinician do, and this patient, of course, had prostatectomy and lymph node clearance. So the surgeon who went in thought that cleaned up everything, but of course he was wrong, and the clinician wanted to see if there are other lesions, and clearly, this patient has had prostatectomy, and then the surgeon thought that took up all the lymph nodes that were diseased. These are just not correct, and doing gallium-68 PSMA agent shows lesions everywhere, here, there. It's impossible for anyone to detect these other than PSMA label gallium-68 images. So these are showing you the essential role of molecular imaging in staging patients with a serious cancer like prostate cancer. So that's why there's a lot of excitement about applications of PSMA. This is, of course, showing you the evidence for cancer in the lymph nodes, as well as bone scans in this patient. Of course, this is also a major, if you want to have a multi-center trial, and the successful New England Journal of Medicine is really turned into multi-center trials. So same thing that I said about neuroendocrine tumors was applicable to looking at efficacy of lutetium 177 PSMA in patients with metastatic carcinoma that was resistant to castration. So we do castration because prostate testicles have a major ill effect on prostate cancer metastasis. So they do prostration, but as I show you, these don't work as well, but this is what gymnastics that you go through with patients with prostate cancer. A lot of really craziness, and we believe that lutetium-177 is going to be the way to go in the management of patients with prostate cancer. So really, this is a very major development of prostate cancer. It's a very common cancer, and I think both diagnostic applications of PSMA agent as well as treatment with lutetium and soon with alpha emitters is going to be a very important part of applications. Of course, radium that you see here, that it only goes to the bone. I'm not in support of it because really you got to directly go to cancer cells. The radium being picked up in the bone is not going to be able to kill the cells in the marrow, red marrow, because it goes very, very short distance. Alpha particles are not going to be as useful. So I think the future is going to be more with beta particles, and these are just examples of what you see in a patient with gallium-68 PSMA positive, all these lesions, and after treatment with lutetium, you see all the lesions. Maybe this lesion is a little bit less, but most of the lesions are gone by lutetium treatment, as you see in these patients. Actually, we can not only see on gallium-68 images of metastasis, but after treatment with lutetium, it's a gamma emitter. We can actually make images of a post-treatment uptake of lutetium in the area. So it's not as high resolution as positron images as you see with gallium-68, but you see evidence that what you have given to the patient has gone to the right places where the tumor is, and that gives you more assurance that this is working. But this is, of course, a patient with multiple lesions with PSMA. Actually, this is change in intensity to show extent of the disease everywhere. And of course, this is really post-treatment, lutetium-68 treatment, that there's been a significant decrease in number of cases, and it just shows that treatment has been efficacious. This, of course, a patient with prostate cancer, and after recurrence and PSMA agents, again showing you all these lesions, and after treatment, this is really going from February to October 2006. These are actually images from America, from Richard Baum, and David has spent some time with him, and it just beautifully shows how effective this theranostics is in treating patients with prostate cancer. These are, of course, the patient with PSMA and uptake in the nodes and in the abdomen, and of course, oncologists recommended to do some typical, studies that they do for treatment of these patients, and the patient comes back, and this is November 2015 and 2016. There's lesions all over the place, and of course, 2 cycles of lutetium therapy, and look what has happened. So, of course, clinicians try to really stay with the conventional techniques, but more and more we've shown that they really have to adopt this approach, and theranostic is really going to be the way to go in the future. This is, of course, a patient again with gallium-68 PSMA agents, and these are, of course, different time points at post-treatment to see that lesions are really going away significantly. This is, of course, very gallium-68. So this patient has response to treatment after 2 cycles of lutetium PSMA, and so this is of course an example of again complete response to treatment with lutetium. Now, there's now a lot of move in Europe, actually more so than in America, to move into alpha particles. Alpha particles have significant mass, 7,000 times more mass than beta. And they really have 100 times more energy transfer. So theoretically, of course, they could really be very lethal to cells. But unfortunately, they don't go very far. That's why I'm not in favor of using alpha particles to go to bone and kill the cells in the red marrow. So I think the beta emitters are going to be more appropriate for that. But definitely in certain settings, we're going to be able to see the evidence for effectiveness of alpha particles. And as you see here, for example, this patient, all the lesions here with bismuth 213, which was done again in Bad Burka with dotatate in the neuroendocrine tumors. And you can see that there's a significant loss of tumors after treatment. And of course here, shown of over time, alpha particles in this patient with actinium. This is another alpha emitter with PSMA that was resistant to lutetium and then responds to alpha particle treatment. So alpha particle treatments are going to be a major player, but they are difficult, of course, to safety-wise. Like in America, we have to go through a lot of difficulties to get approval from the Food and Drug Administration because they are very dangerous, and we have to just make sure that they are safe and can be administered to patients. So this, of course, showing a patient from, again, Bad Burka, followed over the years after and treating for neuroendocrine tumor, as you see here with the lesions. This patient goes from 2005 to 2018. This is fantastic. You have kept these people alive and reasonably comfortable for so many years, for like 30, 40 years. This patient just has having disease under control, and this is really not achievable by any other means. Of course, this treatment is intraarterially can be done, like this is intraarterial alpha emitter, neuroendocrine tumor, a dotatate, and you really get rid of most of the lesions by alpha emitters that you inject through the arteries and get rid of the tumor activities. This is, of course, a patient with alpha emitters with prostate, agent, PSMA, and it's incredible to see how these lesions with alpha emitter are completely gone after 2 doses of actinium-225, PSMA, and it just actually, they put this, no Photoshop, this is real. You see this, all these lesions disappear with alpha particles. This is, of course, showing you over time, and treat these patients with actinium labeled with PSMA, with all the lesions, as you see here. Lutetium didn't work. With actinium, all the lesions are gone. So it looks like actinium with alpha particles are much more effective than with lutetium. So really, the beta emitters may not be as successful as alpha emitters. This is, of course, and again, progression under. So this is the progression under lutetium, and then they were just going on and then going to lutetium, and you see all the lesions that were seen, and is just gone completely. There, of course, happy is a new thing. Of course, that's also coming from a German Heidelberg people, Uwe Herberkorn, and his colleagues in Heidelberg. They really, I used to visit them, and I didn't know how far he's going to go. but definitely they've gone very far. FAPI is a competitor with FDG. You know, as a scientist, I see this fantastic. That, of course, FDG made PET to survive, so Heidelberg has a cyclotron, and they have been very active. And FAPI, of course, is fibroblast. It detects fibroblasts, and you see here, you know, all the different type of cancers, especially GI cancers like colorectal, pancreatic cancers. These are very good for FAPI imaging. So we can definitely diagnostically see some cancers that we cannot see with FDG, or it's not as good with FDG as is with FAPI. But there's also interest in moving FAPI, like labeling lutetium. These are really just trials that are ongoing with lutetium and FAPI compounds. We will see how far FAPI is going to go, and that's going to be very exciting to see. And it's going to start a new domain because, you know, PSMA is good and neuroendocrine is good, but we want to look at other cancers. And I think FAPI is going to make it possible to do that. These are just showing lutetium uptake with FAPI over time, you know, and you know, these are just, you know, just showing the images over time, you know, from this study that was published in JNM. Of course, this is also showing you gallium-68 FAPI images before treatment. So, diagnostic, really, just neuroendocrine tumors, prostate cancer, have paved the way for, you know, just a boom in therapy based on gallium-68 and lutetium and yttrium and now alpha particles. So indications for neuroendocrine tumors and prostate cancer are moving forward, and we're just going to see a lot of early publications and trials, and the demand is going to increase significantly. So our really major concern is how to move this type of activity to many other institutions. Instead, in my country, in America, we have a lot of difficulties, you know, going through the FDA and going through our own radiation safety and human research studies. But this is the right path. You know, this is it has to go forward, and we are very grateful to what Germans have done. And now, you know, other countries are starting to get into. Chinese are getting into this in a big way, because this is really going to open enormous possibilities for cancer. And of course, we are very excited about total body PET. This is really another major development in our field. And this, you know, machine was designed by people at Davis, but United Imaging, which is a major company in Shanghai, in China, is now the supplier of this machine. So they're actually a fair number of them in China. There are about like 10 of them in China. We have 2 of them in America, and I've actually worked on with both groups. One is in Davis, and the other one is in Bank, which is in Michigan. So we can either do better imaging, image quality is better, 6-fold gain in signal-to-noise ratio. We can do faster, 40 times faster. You can just look at the whole body, and this is going to be very important for certain diseases that are systemic in nature. As I said, patients with cancer, the second major cause of death in patients with cancer is pulmonary embolism. So not looking at the caps and ties, which is what we do right now with limited field of view, is not the way to go. You know, we either should look at entire body. FDG is picked up in clots. So we not only can see the lung cancer, we will see the breast cancer, we will be able to see the clot. So we could definitely image the patients entirely, and also we can actually delayed imaging, which is what we have actually looked at. We have delayed imaging, 2-time point imaging requires going later, and FDG is more successful if you look at the delayed imaging. So we can go 5 half-lives. We can actually go up to 10 hours, 12 hours after injection of FDG to do imaging. So this is really adding a major dimension to what we can do. With FDG, possibly with many other traces. Of course, we can give small doses. So this is actually becoming very important for pediatrics patients. We can look at the entire body of pediatric patients, and then low dose and see everywhere. And then cover, of course, entire body for systemic disorders. So this is, of course, a patient that we have studied from BAM. And this patient's got prostate cancer. And we are seeing all the lesions, in the body. And, and then we segmented with this program that we have. So we can actually measure total metabolic volume, SUV for the entire body, SUV max, and total lesion metabolic activity of 3,000. So, and of course we can do partial volume correction for total lesion activity before and after segmentation. And of course, this is just showing you our data, pre and post treatments in different locations. So this really is going to add a major dimension for theranostics, being able to look at the entire body and segment all the lesions and measure numbers, as you see here, significantly statistically valid numbers, and before and after treatment. So the concept of bone metastasis is flawed and should be avoided in assessing skeletal metastasis. So cancer goes to the red marrow, and I want to see stop talking about bone metastasis. That is wrong because cancer doesn't go to bone. The introduction of cancer-specific radiotracers is going to enhance the role of radiotracer-based management of patients with as malignancies. And this concept is going to be very important in the theranostic domain and will really enhance the role of theranostics in management of patients with oncology, hopefully. So this will be applicable to some benign diseases. And sodium fluoride imaging is going to be of great importance in diagnosing atherosclerosis. The cheapest agent we have in nuclear medicine is sodium fluoride. And that's really going to be really just another way to go. So that really ends my talk, and I would be happy to answer any questions for this presentation, but there's another presentation that I will have. I think we should really take the questions right now for this presentation, then I will go to my second talk.
So we go straight to the other one?
Well, I'd like to have if there's some questions, if there's any
Okay,
questions.
so are there any questions in the auditorium? I may have one. This was about the future, but yesterday we were talking about the past a little. So how was the story of first administration of FDG? Your story. How did you get to do the FDG?
Okay.
And how was it the first day?
Well, we invented tomography at Penn. So when I'm an internist oncologist by first training. So for me, cancer is actually a logical place to get into, although I've done a lot of work with benign diseases. So I joined my training program, which was led by a man named David Kuhl, who really was an incredibly important person. It's very much like Hounsfield, who introduced CT. David, as a medical student at the University of Pennsylvania, was a genius in developing tomography. He had the idea of back projection. Namely, if you have a lesion in the brain or elsewhere, if you have a detector that goes like this, it's not going to see any signals until it comes close to this lesion, so you get a line like this. If you rotate, you get another lines of signals. And if you back project these signals, they're going to meet in this area. Very simple, yet this was the beginning of tomography we do. So in 1971, I joined David, and he got me involved with research. I was his little right-hand man, and he wanted me to just get involved with this research. So we used to do 10 brain scans a day at Penn. I used to get patients from all over America, even people from Europe who come to Penn because they had some suspicion of cancer in their brain, either primary brain tumor or metastasis from lung cancer, breast cancer to the brain, and we will look at the blood-brain barrier abnormality. So we have technetium pertectate. We will see leakage of these compounds in the brain, and the rest of the brain was without activity, so we'll see it. So we were very, very successful in looking at brain tumors. Then in 73, we got the first CT scan in America. Came to Penn because of really our research, and our department was very interested in really helping our group to do our research. So we got the first CT scan, and then we saw this contrast-enhanced CT showing the same thing that we were able to see with pertecnetate. So we could see the tumor in CT scan, contrast-enhanced CT scan, but we saw also the rest of the brain. So for a neurosurgeon, telling them go and take up this tumor based on SPECT imaging, which is what we were doing, technetium agent, was not as successful as seeing CT, seeing the anatomy, where to go, how to dissect this tumor off. So my number of just SPECT studies with technetium went from 10 a day to 0 within 6 months. Every patient with tumor, metastasis was going to CT scan. So we said, how can we survive? And that's where the idea of FDG became a reality. We were working with colleagues in neurology. Of course, we knew that there was deoxyglucose concept came to from your country. But we and group at NIH put C14 on deoxyglucose. So we will inject in C14 deoxyglucose to rats and mice, and then about an hour after C14 was injected, we kill the animals, make slices of the brain, put in a radiographic film, and develop the film called autoradiography. So we were seeing this beautiful uptake in the gray matter of C14 deoxyglucose, because deoxyglucose goes to where glucose goes, and brain uses a lot of glucose. So these were just done in animals. You know, we were just activating like whiskers of the rats and seeing sensory cortex in the brain or visual cortex. We were seeing if you put a lot of light in the eye, you see a lot of the occipital lobe uptake, because that's where visual cortex is. So that was sitting there as a just laboratory research. And we said, how can we survive now that CT is taken or completely SPECT away because we were using technetium? So we decided to put fluorinating on the deoxyglucose. This is December 1973. So we talked to people at Brookhaven National Laboratory who actually had also contact with colleagues here, because the concept of deoxyglucose started in Czech Republic, so in Charles University. So we talked to chemists there. They have a lot of cyclotrons. You know, Brookhaven National Laboratory sits in the middle of Long Island. Long Island is like a square here, like that, to the east of Manhattan. They had every machine, but only a bunch of chemists and physicists were doing. They didn't know what to do. So we went there and we told them, we want to put fluorinating on deoxyglucose and then do human studies, because C14 deoxyglucose is working so well. C14 is, of course, only beta emitter, so we couldn't definitely use it in imaging and humans. So they really worked hard on it. This was December, as I said, 1973. By August 1976, we had the first dose of fluorinating deoxyglucose made in Long Island. We flew by a private plane from Long Island to Philadelphia, and I had two medical students who had working with me, and I sent one of them to the airport to pick up the FDG, and he was speeding on the highway, and the police stopped him. Why are you going in the 65 miles an hour in a road that has got 50 miles an hour speed limit? And opposite, please let me go. This is a bucket of water in a bucket, and there's a hole underneath it. It's leaking, so we have decay. So thank God the officer let him come, because we just reward that we won't have enough activity to give to first volunteers. And he brought the FDG, the first dose, to the lab, and I injected it to another medical student, and I did tomographic images of the brain with only using one gamma ray of 511 keV. So that became the first tomographic image of the brain. But what I showed, of course, in my talk, total body, that took 2 hours. I'm going from here to proximal here. And of course, the rest is history. You know, we, of course, became interested in brain. I mean, my initial work up until about like 1979, actually, we got a body machine to Brookhaven National Laboratory. So every week, I used to travel from Philadelphia to Long Island to do the first studies of various diseases until we got our cyclotron at Penn. It took a while. We're talking about how difficult it is to establish PET. So this is our life story. Not everything just tell our life from nowhere. So I used to go there I will do the first seizure study, first brain injury study, and I bring those pictures, some Polaroid pictures. The old time, we used to have Polaroid pictures. We didn't have anything modern. So I used to bring every Monday images of that acquired on Thursday and Friday of the week before from Brookhaven to show my colleagues. And fortunately, you know, we got the total body coincidence system, and also I have to tell the story about cyclotron. You know, we didn't have a cyclotron at Penn. And so we got money from the NIH to put a cyclotron at the University of Pennsylvania. So we had the space allocated very close to our imaging laboratories, and I was, this is 1985, and my chairman comes to my office, knocks on my door, Abass, I'm taking your space away. Why? Because MRI is the future. I'm getting the first 1.5 Tesla unit from GE. They're putting it at Penn, and you can get lost. Do whatever you want. The cyclotron is not going. So we had to put the cyclotron about half a mile away, half a kilometers away. We had the capillary tubes from the cyclotron to bring oxygen 15 to the imaging facility. Of course, that capillary tubes got clogged. I never used oxygen 15, but because they thought MRI is going to be the solution. You know, we had a very famous, scientist who really was, his name was Burton Chance. He was the greatest NMR spectroscopist. And in fact, one of your colleagues, just trained with him. So he really just, of course, he was very much aligned with radiologists, and they just were young scientists trying to survive in a major institution, and they would just keep on telling me that they're going to do everything with MRI. And especially they thought NMR spectroscopy is going to be the greatest thing under the sun, and definitely they're going to come up with a lot of compounds to do with MRI. I knew that they're not going to be able to do it. There's 1,000 times sensitivity difference between MRI and PET. So if I were to put fluorine-19 on deoxyglucose, fluorine-19 is MR signal agent. You can get signals from fluorine-19. If I want to do fluorine-19 deoxyglucose with image, I have to kill the patient. In order to get enough signals, I have to give 10 grams, 20 grams of FDG. And clearly, that was not the case. So really, you can see at an institution where really this technology was born, and it's a major institution. We really introduced, actually we discovered X-ray at Penn before Röntgen, but they never published it, and so Penn didn't get recognition. So it's a major institution, a lot of powerful people, and I had to struggle to really move PET going. Fortunately, we succeeded, and this has made the world a better place. But this is really how FDG history evolved and allowed us to really survive and also contribute to the world. And every year, like 10 million people are benefiting from FDG. 20 million people, they're not going to surgery because FDG shows that there's no cancer. So this has been an incredible path for me and my colleagues and patients, who are #1 subjects in our world as physicians, not to suffer or suffer less. I mean, this is really an amazing journey, and that's why I don't want to retire. I still want to go and help more. My southern fluoride, I want to diagnose atherosclerosis, total body atherosclerosis. So that's the story of really what we have been through at a place where there was a lot of innovation and a lot of good thoughts.
Thank you very much. I think now we all know how it was. We all know how it was. Thank you for sharing this experience. And Abass, Professor Alavi, has prepared also some recommendations and his point of view, how to promote PET. Those are 20 slides. So 20 hints or 20 advices. So maybe we can go through it and then move to the area for smaller discussions. So shall we do it? Okay.
Whatever, yeah.
Okay, so tu druhou prezentaci, prosím.
Okay, so, having been really involved in the difficulties and bumps that we have encountered in developing and establishing PET Center at Penn, of course, similar things have happened in major institutions. For a while, there was only 5 PET centers until we got insurance payment in 1999. So we did the first study in 76. It took 24 years or 23 years before our government insurance company paid for it, and then private insurance paid for it. So really, it wasn't only just us. While CT and MRI was accepted within months of the introduction, it took a long time for us in America, a rich country, a lot of activities to really accept PET. So what really I want to do is to really tell you how we can, if you could check, is it going to the next slide? Oh, you see what to do this with?
Yes.
Okay. So in order for me to really help you to get the going, I just don't think that we should really have only PET scans in only 2-3 medical schools. And this is good for patients everywhere, not only in Europe and developed country. It's going to be important for somebody in Ghana or just anywhere in the world should benefit from this very important. I don't want to see patients go to surgery who don't have cancer, get mutilated, get disabled because of surgery, even die from it. So we believe that this should happen in a developed country like yours, and then we should have PET at least in major institutions. So my talk is really, just educating the community about the importance of this modality, not only among colleagues, but even politics. Somebody in the Ministry of Health, Ministry of Education, or other government agencies should realize that this is a very, very powerful modality, and we really have to just get people educated. So I like to, I really like to educate young people. So this is a very important part of really starting point for preparing the future generation, and especially students who are interested in the basic sciences, mathematics, physics, and they're either looking for something that's exciting to do. You should just grab them. As soon as you see somebody, a medical student comes to you and says, I'm interested in something related to PET, grab them, don't let go, because that's going, if you want to build any organization, you hire the right people, you train the right people. Building buildings without people running all the facilities, it's not going to do any good. I always tell people, if money and buildings are going to be important, Saudi Arabia should have the best country in the world. They have more money than they know what to do with it, but they don't have the manpower. So manpower is a very important part of any organization. You hire the right person, everything is going to come after that. So talk to medical students and just make sure that you grab them if they have interest in participating. Also, try to really get involved. training residents, fellows in fields that deal with molecular imaging or imaging, like radiology resident, radiation oncology residents, medical oncologists, of course, cardiology, all these specialties that are really related to what we do in molecular imaging, and that's going to be very, very important. Make you, also invited to some specialty conference. Honestly, I've knocked down people's door, oncology group. And they come to your conference when you've got tumor boards and sit there, and when they realize that PET can do something good for the patients, that they're only looking for CT and MRI. Answer, I raise my hand, and of course there's been some resistance to it, but now we have solved it. They will not touch a patient with cancer. So the same thing is applicable to radiation oncology, the same is applicable to cardiology, specialties that really relate to our discipline. But, the attract the talented students have great desire, applications of, I think, physics, chemistry in our specialty. And technical staff should really learn how to use these instruments. You've got a PET machine, just make sure that your technical staff really know how to do the better quality control, because we are talking about quantification being a major part of it. If you don't do everything right, calibration, cross calibration, you're not going to get numbers that are going to be correct. So you got to just train your technical staff so that they really just are aware of all the subtle things that they have to take care of. You have to have at least weekly or monthly meetings with the technical staff to make sure that they really are doing everything right and everything is up to date and they're doing optimal quality control with the instruments, cross calibration, dose calibrator versus PET calibration, so that images that you're getting are high quality and reliable for quantification. Now, requirements for approval for research. And there's places that you've got PET machine, and you've got, of course, in my country, we've got two committees. There's a human use committee, we call it institutional review board, and also we've got radiation safety. So the protocols that we give goes first to human research institutional review board, and to make sure that from the point of just medicine, these are primarily internal medicine oriented, just different disciplines of medicine, they're reviewed, and if they approve it, then we go to radiation safety to make sure that we're not giving excessive radiation. We have, of course, our FDA and NRC, these are really organizations that deal with radiation dose, so we cannot exceed beyond certain levels. This is applicable especially for research, but even for day-to-day practice. We just have to follow the rules that are established in our institution. So be aware of what these organizations in your country require, and of course be in contact. And this is a very, very important part of getting a lot done with PET. So, of course, the regulation, radiation safety issues, as I discussed, and that's very important. Convince private and government agencies to cover costs for performing FDG PET. So I've been, of course, being pioneer in this area. I have been going to our government agencies. As I said, it took a long time for me and sort of a lot of people to deal with our government agencies to pay for. In our country, 95% is private. In contrast to Czech Republic, that government covers expenses. In America, 90%, 95% of the medicine is in the private hands. So we had to really talk for government agencies. They approved it, and insurance companies pay for it. So, but you have to just be able to convince them that this is not a research tool that Alavi wants to do to get his name on the literature and get papers, get grants. This is good for mankind. So it's very important for us to educate our the government agencies and if there's private agencies in your country, so that we either get paid to do these studies, and that's a necessity. Now, like I'm sure the government in your country pays for some research. May not be as substantial as in America. We have got like $100, $200 million a year that goes to research. Of course, PET is a very small part of it. You have a lot of oncologists, you have a lot of cardiologists, you have a lot of neurologists. So we have NIH, National Institute of Health. So we have got also basic science, National Science Foundation. So they pay for research activities, but you have to compete with. Or in our country, like you get only 20% of the applications that goes to the NIH get funded. For some areas like cancer, right now it's only 10%. But you got to just knock on their door until you get grants. And in your country, both the government and private organizations, you should just try to get some funding and do as much research as you can with those funding. At least you should have 2 national meetings every year. So this is the Society of Nuclear Medicine in Czech Republic. We meet twice, of course. We have national meetings as well as local meetings. We have like Pennsylvania, New Jersey, New York. We have our own meetings, twice a year, but also we have the Society of Nuclear Medicine meeting that's once a year. That's for the entire country. So it's very essential that you get together with your colleagues and exchange ideas and try to attract as many young and highly motivated people to attend these gatherings. It's very important for young people to see what's happening in the entire country. And that's what we see, Society of Nuclear Medicine meetings we have a lot of young people. We pay for their students to have a hotel reservation, plane expenses, to attend these meetings and learn about what's going on in the country as a whole. Of course, for Society of Nuclear Medicine, we get a lot of people from Europe, a lot of people from China now, and Japan and South America. So you see a lot of people, and similar models should be done in the local level in the country as well. I think that's a very important part of it. Of course, provide mentorship to trainees in the field of both clinical and research settings that deal with PET applications. I mean, this is something that, again, talking to trainees in clinical and research settings, these are from other disciplines. The cardiologist is interested, the cardiology fellow is interested in PET, try to help them, give them projects, do something to really get involved and do something that's going to go all the way. And that's a very important part of really, just getting future establishment of the PET in your institution. To interact with basic scientists. Honestly, one of the reasons for our success has been basic scientists. Like we have had in our institution, in my department, we had chemists right from the beginning, but I try to attract physicists who were interested in PET, design of PET machines. So we built actually coincident system by a very great chemist, a very physicist who came from Germany to America, and I really attracted him to come to Penn, and we have built up a very strong physics school. I mean, right now we actually built it up a body PET at Penn by the physicists that I had hired. So these are very important people. Of course, chemists are very essential. We have right now at least 15 chemists in our department, as well as, of course, 10 physicists. So these are very important elements of developing PET in institutions that are research-oriented. It may not be that easy to do in Czech Republic, but at least do your best and find a way of funding these people so they can contribute to your research activity in the future. You have to get Sakata. That is a must. Sakata is the centerpiece of PET. If you don't have Sakata, you're not going to be able to use carbon-11. Carbon-11 is 20 minutes half-life. If you try to get carbon-11 made in a facility that makes carbon, by the time you bring to the facility, it's all gone. So, and of course, oxygen-15, I mentioned 2 minutes half-life, oxygen-15. So, but even beyond that, if you have an idea, somebody in basic science in your medical school is interested in labeling the compound that is showing promising results, autoradiography or by chemical means, you need to have a cyclotron that the chemist can label that compound and use it in the facility. You're not going to get a commercial company make the compounds for you. They're interested in making money. They're not interested in research. They're not going to spend a lot of time making a compound that takes 2 hours of time of a cyclotron and take them away from making thousands of dollars. So you got to have a cyclotron. And I'm just telling David that you really have to just directly talk to the Minister of Health, anybody else. Put cyclotron in 8 medical schools that you have in your country, because that has to happen. It should happen now, other than 10 years from now. Just start the planning, constantly bang on their doors until they respond. They open the door for you. So we have to deal with really, and of course, chemistry facilities. We need these chemists, and again, attract these chemists, because we're going to need them to do, both clinical and research. If you make your own compounds, it's going to cost no money. You've got the facility there, you've got a chemist or a technician who can make it. After you synthesize it and validate it, you can have a low-level person to make it. You don't need to have a chemist to do this. You can have a trained technician to do that. Of course, instrumentation are the first companies. Again, there are some of them in Europe, and you really have to deal with them and try to get some of their compounds for initial testing, rather than having the Germans to do that or French do that. I think you should try to attract and just play a role in helping them to really move in their projects that are interested in clinically applicable areas. In our area, in our country, we promote people based on number of publications, and to some extent, even citation. So, in order to stimulate the faculty to do research, you have to just get them published in high-impact journals. So, of course, PET has been, luckily, one reason that I have a lot of citations is that what we do is very novel. It can get published in major journals. And I think that's really going to be very important for you that really just, be able to do, and then try to, of course, give people tenure track. And I know how the situation is in Czech Republic. We have got 2 types of track in that packet. We have got tenure track, which really means that nobody can fire you, and then we have got standard track, that if the chairman doesn't like you, they may not just approve your involvement in the department. So, but those who get tenure track in America have to be very established persons. They have to have a lot of publications, and ideally, they should get grants from the government and other agencies. So, making it a tenure track dependent on publications is going to be very important for people to really do high-level research. So, some seed money, we have seed money for starting, like our department pays $20,000 to start a project that I want to do natural sclerosis, like an inflammatory bowel disease. So it would be nice to establish this seed money, however you can get it. I don't know if the government will pay for it, but definitely from some source, and that really will allow you to generate preliminary data, and hopefully that will go all the way to getting a bigger grant from the outside. Pat, really try to help your colleagues who are applying for grant applications include PET. This is really what we are seeing happen in many domains, whether it's cancer, whether it's cardiology, whether it's gastroenterology. We try to just show that we have the tools ready for them and strengthen their application. So to include PET as part of the institutional applications will be a very important way to really enhance your research. European and intercontinental education and research symposia should really include Czech Republic. however you can do it. You know, you have to show that you are a player and just find a way, really penetrate the system and again compete with countries like Germany, France, or Northern Europeans now. They're getting into a big way. So that's really going to be the Netherlands. You know, they're really becoming very big. Netherlands is at a lot of pet centuries. So really you have to compete with these organizations. So cost effectiveness is going to be very important. I mean, this is what we did with the insurance companies, that if you do a pet and you pay $1,500, that stops you from doing the surgery that in my country costs about $100,000. So really, this is going to be very important for both government as well as private insurance companies, as we have done in America. We have just shown that allowing us to do PET, because we have to call insurance companies, private insurance, to do PET scan. And we have convinced them that the patient with lung nodule, that you don't know if it's cancer or not, doing PET scan and show that it's not cancer is going to save the insurance company $200,000. That's what we get in our department, in our hospital. You come to Penn and get lung nodule removed from your lung, and then of course put on the microscope, it's benign, it's not cancer, insurance company has to pay $200,000. While doing a PET scan for $1,200 would say give answer, the patient goes home and glass of wine, doesn't have cancer, and of course we save $200,000 for the insurance company. This is a very cost-effective modality. We have to educate people about that. So those are my just advice to you, and hopefully, you know, some of it will become a reality in your country. Yeah, just you know, it's been an amazing journey for me to go through starting a new specialty and making it succeed and prosper. You know, in my view, I've been telling everybody the most important modality in medicine is PET. There's no question about it, but it has not been a smooth ride. A lot of bumps, a lot of obstacles on my path, but I've been able to jump over them, one after another, and don't give in. Don't give in life. Don't give up in life. That is really advice that my mother, you know, who was raising us without the father, told us that we're not going to give up, we're not going to give in. And that's what I used to hear from my mother, and that applies to PET. Don't give up, don't give in.
Thank you for your presentation. Thank you for advices. I have to say, explaining the Czech reality to Abass was one of the hardest tasks I've ever had, and I think that we are still not there.
Thank you.
It's been 2 hours. We've heard a lot. Thank you very much for taking this long journey over the ocean, coming to us. We thank you for all your life's work, because somehow we can follow your legacy. You say PET is the best modality, FDG is the king, and it will be, and we fully agree. And we will do as much as possible from your slides to, as you have said, bring the PET into the country in big. So thank you a lot, Abass.
Well, thank you for inviting me. Yeah, this is a very pleasurable episode in my life, visiting colleagues around the world and exchanging ideas. Especially, my heart goes to young people. I want to just lead them in the right path by words or actions, anything we can do. I mean, young people are the investment of every society. And so it's been a pleasure really being in your city, in your department, and meeting so many nice colleagues that you have.
The problem is Abass has made our young colleagues tired. They have been together yesterday, and I've get the notice. We were so tired, and he wanted more. So thank you again. Admirable, admirable.
Thank you.
I think don't hesitate to visit Professor Alavi, shake his hand, talk to him. He loves this.